English, the endourology, the ureteroscopy is the most frequent of all the procedures for lithiasis in the upper urinary tract. While traditionally we have been talking about the 3% of strictures after ureterorhinoscopy, the truth is that in the centers of reference, they are talking about a real epidemic of ureteral strictures. Of them, 30% will require derivation, and at the end, around 5–10% will end up with reconstructive surgery, which is not nice and not easy in terms of the ureter. So, which is true that there is a mechanical component, is also to be thinking that with the laser, with the high energy lasers that we are using at this moment, they also play a role in thermal ureteral lesion. And then the second one is, what is a robot? And that's what you have been talking, Javier. They are gaining momentum in endourology. Well, a robot is basically a machine which is programmable by a computer. It is, and is capable of carrying out complex tasks. It has to have sensors. We give the robot an idea what's the environment, which the setting, which is around. It has to be a brain, which is the software which is able to process the information and gives the order to perform the actions. Which is true that we talk about robots. Still, we do have, and most of the so-called robots in the urology are no more and no less than master-slave machines, which are controlled still with the movements of our fingers. I cannot go on with slides. I don't know if it is my, can you take the, okay, perfect. Take the control, and I will let you know. The first robot appeared for endourology of the upper urinary tract in 2008. And the first publication, or the first one who was commercialized, was the Avicenna from Roboflex. There is quite a number of literature, not a lot, but it's respectable literature. But then there was a gap from 2017 to after COVID, and in 2023, and in the last 3 years, in fact, it seems that we have been doing quite a good job in developing so-called robots, man-machine interaction in the upper urinary tract. What do we expect from a robot? To give us a better sense of the navigation, to provide with a lower radiation exposure, to improve the stone-free clearance, and to lower the rate of ureteral lesions. Can you pass the next slide, please? The first one, and it's to talk a little bit about it, it's worthwhile to talk about the Avicenna in the beginning, has 440 degrees of rotation, half to the right, half to the left. It can move vertically and laterally, and consists in a controller with a touch screen and some joysticks to control the movements of the ureteroscope. They say that is much more precise than the hand, and the stone-free rated, who has been just published by the group of Germany, is around 90%. It's ergonomic, that's no doubt that the surgeon is much more comfortable, but on the left side of the slide, you can see that still the learning curve is not 10 cases, but it goes on up to 50 cases with the robot. Next slide, please. This is just to show you what has been happening in the last 3 years with the robots for the upper urinary tract. After Avicenna, the French developed the ILI robot, the Easy Uretero, which is the second generation, the Samenix, and the Monarch. Especially the last two, in the last 2 years, they are compatible not only with the laser, but also with baskets. They have suction, they have irrigation, and the Monarch also has an electromagnetic system who allows you to target very well the puncture of the calyx. 2 of them have the European mark, and 2 of them had accepted by the FDA, the Samenix, the second generation of Easy Uretero. The trial has been published just a couple of months ago, and is pendant, is a Korean robot pendant of being authorized to use outside Korea. Can you pass, please, the slide? Important is, and people sometimes doesn't pay enough attention, the hand control. The easier is the hand control, the more precise is gonna be the movement of the robot, and the better we will be navigating. Actually, from all of them, you can choose the one which is more comfortable for you. For me, the gimbal handle, the last one, which is like a TV control, then it's the easier one, but others can have different opinion. Next slide. Do we have what we have been expecting from the robots in terms of outcomes? Two systematic review here, the data of one of them, for both of them published this year, with very similar number of patients, very similar number of articles, and more or less the same results. The docking time of the robot, quite acceptable. The mean surgery time, more or less the same one as without the robot. The pool stone-free rate, 86%, is not bad, of course. Still 11% of complications. They are safe, effective, ergonomic, and prolongs the life of the endoscope. Next slide, please. But of course, 86% of a stone-free rate doesn't really be much better than what is already a classical result. This is a study of the CRUS with more than 11,000 ureterorhinoscopies. Is all classic, but is still valid, and the stone-free rate is exactly the same that we were having without the robots. Postoperative complications that were not very well captured, all of them, but still we have to know if we improve the rate of complications. Next one, please. Just a couple of words about the last one, the Xamenix that I told you, developed in Korea, very nice, and it looks to me very ergonomic. 46 patients treated, multi-center, which gives you generally, it makes the results general, and with slightly higher stone-free rate, 93%, much better, but still ureteral injury of low grade, but eventually that may result in ureteral stricture of almost 20%. This, besides the fact that all the patients were pre-stented. Ergonomic, very good ergonomics, but still it's not fully complete we expect from a robot. Next one, please. This is a little bit, you can push the videos, please. This is a little bit a ureteroscopy, although we think that is easy, is a complex task. The other video also, and it's like driving a car. So you have to keep on the same lane, you have to keep the distance, the safe distance, but at the same time, you have to look to the rear mirrors, the rear view mirrors, and you have to push the pedal. So it's not so easy. Next slide. So what has been thinking is, can we improve the performance of the robot just adding a new sensor? And this new sensor is as a tissue sensor. You can go on the slides, please. Go on, please. Yes, there is also a video. This is a new sensor, which is just incorporated to the laser and which is able to differentiate the stone from the soft tissue. You have to calibrate the laser before. This is already being trialed in outside of the European community. Next slide, please. And you can see here very good in the slide what happens when the tissue sensor is off. So the laser is just acting over the stone and is also just destroying or causing lesions in the soft tissue. The next, on the right side of the slide, you see what happens when the tissue sensor is on. So you can continuously press the pedal, and the laser is only going to act once you are in contact or near by the stone, and will stop acting when you, for one reason or another, should just approach the urothelium. Can you go on, please? Next slide. A little bit. Just push all the videos. Yes, all the videos going on. On the left side, the laser acting, on the right side, not acting. Then in conclusion, yes, there has been a lot of research in the last 15 years, but still we are working not with really robots, but master slave. That's good, but probably it's going to change in the future. They're more complicated, more integrated, more perfect master slave systems, and we can work with much more, how you call, much more performance, much more toys than in the past. However, the rate in terms of robotic lithotripsy is not yet mature. We really didn't have a lot of advance using these robots. The remain cost, we didn't talk about cost, but they are really expensive. All these robots, and this has been, of course, limiting their use. And in this scenario, if we can incorporate this sensor, which is already, as I told you, outside of the European community, is already used, and we expect the results quite early, then we can introduce a new capability which may reduce the thermal lesions and may improve the results in terms of complications. I thank you very much for your attention, and I will remain here to answer whatever questions they are.
Thank you. Thank you, Pilar, for your wonderful presentation. We do appreciate very much. I don't know if we have any comments coming from the floor. Guido, you like one of the most important endourologists in the world. Which one is your opinion in this?
Pilar, this is Guido Giusti. Good morning. I have a comment or a question. I think that a key point is the following. I remember that in the beginning of a laparoscopy, there was at a certain time some robotic manipulator of laparoscopic tool. And they didn't succeed because at the end, they were doing the same thing that the surgeon were doing with their hands. So I have this feeling robotic ureteroscopy will succeed only when it will imply dedicated scope of the robotic system, like Da Vinci. Da Vinci is manipulating his own tools, not a laparoscopic tool. And this is the same, because actually, at the end, the robotic system that are manipulating stores, Olympus or other scope. What do you think about that?
You ask me?
Yes.
Well, you may be right, of course. Actually, the Da Vinci is no more and no less than a manipulator with their own instruments. So that's good. Then it corresponds. I can only tell you that in endourology of the upper urinary, the things have been going on the other side. So the new robots, like the Korean one that I was presenting, you can adopt, or they practically any scope in the market. So maybe you are right, and then we have to instead of focusing on changing our manipulator, maybe what we have to do is to develop one scope, especially for this manipulator. This, of course, is going to increase the cost. It's going to make this scope a sort of disposable scope. And the question is if we will be able to pay this or not. So
because at the end of the day, honestly, apart from the cost, you show the data that are not enthusiastic. 1 hour and a half for 1 centimeter stone is worse than what I can do with my hands. So why I have to pay 4 times more to have a result that is not even the same? But of course,
at the present, you should not do it. You should not pay it.
yeah.
That's
So
what it is. That's what it is. But on the other side, what you see is that after COVID, all the industry has been just blowing. So if you go, I'm just coming from China. If you go there, you see that there is one robot after the other. And those robots are not most cost effective than the Da Vinci. So that's the same that is going to happen with the endourology. But Guido, you know as well as me, if you don't have a Da Vinci right now, you are a no-no. You are a nobody.
Yeah.
You know what I mean?
I do know this. In Milano, they don't even go to the bathroom without the Da Vinci, actually.
Exactly. So I cannot tell you if this is going to happen or not with the endourologist. I only know that there is there, and we have been advancing in this. Are they manipulators? Still, they are manipulators. And you may write, maybe we will need is to buy the machine and then the scope already inside.
Well,
Yeah.
I think we are in the beginning of all this robotics for endourology. They need time, but for sure they will be at the end in all our institutions. So thank you, Pilar, for being with us. We do appreciate very much and receive our big applause for your intervention from the auditorium.